Dr. Saraswati Devi, Madam, to the dais. Madam is presently Professor and HOD of Anesthesiology, Oxford Medical College Hospital, Bangalore. Her major achievements are she is instrumental in the amendment of Narcotic Drugs and Psychotropic Substance Act and simplified the rules of oral opioids and availability to cancer patients in Karnataka. She has many honors to her credit, like WHO Award to conduct research on cancer pain management at Hopkins Oncology Center, USA, and recipient of DAME Cecily Saunders Award at UK. And she has received National Award from ISM Metro Branch, Bangalore, and from All India Difficult Airway Association. She has many publications like 16 national, 12 international, and she has authored chapters in textbooks. Welcome, ma'am, and over to you, ma'am.
Good morning, dear colleagues and dear postgraduates. I would like to thank the organizing team for giving me an opportunity to be with you all. I think earlier speakers spoke about most of the scientific aspects of modulation and cerebral pathophysiology. Mine is pain management at the end of life. See, end of life is introduction means it's not the pain management normal life. It is only few days, during last few days or few weeks or few months. Patients is progressively health condition is in a declining phase, not in the static phase, and one should know that they should be equipped with knowledge of how to treat a patient in end of life, and pain management is very important. It is not well understood or not recognized by many physicians or the palliative care. People can do it with good experience, and we must make the patients to die with dignity. This is the end of life evaluation. If you can see, there are few things which we need to see. It is mostly under recognized and under addressed. And there is a survey done by 36 patients, unanimously told that there is a first priority is to have a pain-free death. So even I think we also want that pain-free death. How pain can be relieved at the end of life? There are many number of pharmacological techniques, and of course it is addressed by the total pain. The pain is the most feared symptom, not only in cancer, even in late HIV diseases, and we could see in many of the degenerative diseases and end stage organ failure also, it is most commonly seen. If you look at the prevalence, advanced cancer, of course, if you ask a cancer patient what is your wish, they say that I wanted a pain-free death. It's not that they wanted anything for at the end of life when you ask. That is the main thing that most of the patients ask for. 20 to 25% of the patients with advanced disease definitely complain of very severe and excruciating pain. Then the cardiovascular disease and heart failure, 75%, I think it is. I could see this. There is a lot of people suffer from pain. It may not be very severe pain. It may be moderate to severe pain. And in HIV disease, HIV, it is not only due to the virus, it is due to the treatment. In palliative care setup, HIV people suffer from very severe neuropathic pain. We should know what are the modalities of approach and how we can deal with. Then apart from that, we have neurological disease they often experience pain. It is not that percentage linked or anything statistics based, but there are multiple sclerosis, Parkinson's disease, central pain related, spinal cord. Most of the spinal cord injuries, they often experience pain at the end of life. Then how do you assess? When you start the treatment, you need to assess pain. How do you assess pain? Routine assessment is what we do is by noting the duration, history, characteristics, alleviating factors, aggravating factors. It is not possible at the end of life. You can't sit with the patient and ask the history, you can't note down, you can't assess. Then ongoing assessment tools we have, like visual analog scale, then is behavioral pain scales and critical pain observation. All this is very, very crucial when the patient is at the end of life. So dementia, when you look at dementia, why there is a problem? Because there is a cognition, decline in cognition, and communication also is not possible with these patients. Then how do you do management of pain at the end of life? One should have a good knowledge of pain pathophysiology. That is very, very important. See what previous speaker explained, Dr. Madhusudan Reddy and the previous speaker explained how pain pathophysiology, how it goes, what is the peripheral modulation, what is the spinal modulation, what is cerebral modulation. It is very, very important how the descending pathways act. See, pain is a pain for everybody. Why it is not well understood? Because not many people are interested. When you take the books and start reading, you will not be understanding what is pain pathophysiology. So that is, in a way, it is very, very important to give a pain management and good pain relief at the end of life. And another one more thing, you should have a clear demarcation or a difference between disease related pain and patients facing death related suffering. There is always, we get confused, and the I think new or young physicians get confused with patients with lot of emotional conflicts and psychological conflicts, and they nearer to death, patient has suffer from lot of suffering. So we require experienced multidisciplinary professional team approach, and they should have a compassionate people to deliver comprehensive approach. That is extremely important. This is the end of evaluation of management of pain, and this study shows that most of it is under recognized anyway. There is a main priority is a pain relief, and Dame Cicely Sanders showed that, last paragraph shows that in evaluating pain is, you should have, there are 4 components of end of life pain or total pain at the end of life. That is not only the physical noxious stimulus, there is emotional discomfort also causes pain, interpersonal conflicts. When a spouse is having a major illness and she is at the end of life and she has lot of revenge against the husband, because we had seen many number of cases, and they will not allow, I am dying and my spouse is going to live. They will have lot of interpersonal conflicts which one person cannot deal. As a pain consultant, you cannot deal. You require a clinical psychologist and community person, and you have a physiotherapist for other things. Is a professional multidisciplinary interpersonal different approach is very, very important. And non-acceptance of one's own death. If the patient accepts death, half of our problems are solved. When the patients are young, they will definitely not accept death. Now I have right now is a 32-year-old female, is having 2 children, and she has advanced disease. Name everywhere the disease has spread, and she is not accepting the death at all, and she suffers from very, very severe pain. Then how to go with that? See, pharmacological management of pain is, pharmacotherapy is the main modality of team approach. As we all know, I am not going to tell much about it, is the WHO analgesic therapy. What it emphasizes is round the clock analgesia. Please don't give intermittent or PRN analgesic administration. That provide inadequate pain relief. Only when do you give PRN doses is only when there is an episodic pain. When there is an immediate something, when they want to have an activity, when they go for an activity, they go for a bathroom or just walk. So at that time you can give PRN doses, but regular routine PRN doses as and when the patient complains, it doesn't act at all. Analgesic therapy, you all know what are the analgesics available. It's a postgraduate question also. Non-opioids, non-steroidal anti-inflammatory drugs. I'm not going to go in detail about it. Weak opioids, adjuvant. These are all, now they have included the interventional neurolytic blocks also in this analgesic. So challenges in pain management at the end of life is very, there are a lot of challenges we experience as a palliative care consultants. One analgesic is not sufficient. There are other many number of modalities of approach, other routes of approach also we require, other modes of analgesics we require. Then see, somatic nociceptive pain, and everybody knows that it is non-opioids, non-steroidal, but usually for other pains we prescribe non-steroidal. In end of life, non-steroidal anti-inflammatory drugs are not well tolerated and they have very severe adverse side effects. It limits its long-term usage. So always think about using non-opioids as analgesics in end of life. And adjuvant analgesics, we have many number of adjuvant analgesics. If you look at, we have many. Adjuvant analgesics are the add-on analgesics. Apart from the regular analgesics, we add on these analgesics to give a good pain management, pain relief. Then others, as usual, muscle relaxants and anxiolytics. So moderate to severe pain, we have in India. I am going to speak about what we are using right now, what are the drugs available in our country. We have only morphine and fentanyl, we have strong opioids available. There are not only very potent analgesics, there are mild sedatives and anxiolytic properties. That's why we use extensively these opioids, strong opioids in end of life care. See, oral morphine tablets are there, oral morphine preparations are there. It can be used titration with immediate release preparations against pain. We need to titrate 4th hourly and then standardize this to 12th hourly sustained release morphine, convert it to sustained release morphine to sustained release morphine tablet, immediate release to sustained release 12 hourly. From this again you can change to equianalgesic doses of transdermal fentanyl, because transdermal fentanyl patches are everywhere. It is used and it is used for action is for 72 hours. So transdermal patches, first you have to titrate with morphine, immediate release, and convert it into sustained release morphine or transdermal patches of fentanyl. Then pharmacological management of pain. Then morphine metabolites, this is very important. We have very active morphine metabolites, 6-glucuronide and 3-glucuronide. And in renal insufficiency, accumulation of these metabolites causes hyperalgesia. See, when I joined Kidwai in 1989, and when we start morphine, many of the patients used to come, not many, very few of the patients used to complain about very severe pain after morphine. I always, in our country, why after morphine, why we should have pain? It is a strong opioid. After 10 or 5-6 years later, we found out that, we means not me, this is evidence-based studies and research found out that addition of or accumulation of morphine metabolite, morphine 3-glucuronide, producing hyperalgesia in some patients, and we also had seen around 7 to 8 patients of severe hyperalgesia. It is very difficult to treat. Morphine hyperalgesia, you have to stop morphine and rotate morphine to another opioid. Then fentanyl, it is a synthetic opioid. As you all know about this, it lacks active metabolites. I want to stress here is fentanyl is a safer drug because it lacks active metabolites and it is better tolerated by the patients, and constipation and vomiting and side effects of morphine is less with fentanyl. And fentanyl routes of administration is, see, we always think in general pain of cancer and advanced disease, oral preparations are better. But in end of life, you can't say that oral preparations they will take. They have done a lot of big studies, and they have proved that evidence or studies shows that 50% of the patients cannot take orally. They are not in a position to take orally at the end of life. So you have to give further other parenteral routes of administration of opioids. We have transdermal patches. It acts for 72 hours, lozenges, sublingual, nasal sprays, and subcutaneous, intravenous, neural, other preparations, you know. And you have the breakthrough pain. Breakthrough pain is a transitory exacerbation of pain experienced by patient. Usually we give OTFC, buccal fentanyl lozenges are available. We call it as a lollipop, and it acts within few seconds. We have sublingual tablets. These are all which are used for end of. We'll see ethical issues. And palliative physician should be equipped with the knowledge, not only the knowledge, experience is extremely important, and compassion to present and optimal pain management plan for this vulnerable population. And good death is as important as good life and will be remembered long by the caregivers. If you ask a caregiver how your so-and-so has died, they remember the end of life, how they died, not how they lived. So end of life, as a consultant, palliative care physician, you should give importance. You should make them die with dignity. With this, I conclude my session.
Thank you, ma'am, for the wonderful